what is trauma? Trauma is a deeply distressing or disturbing experience. Adversity is a state or instance of serious difficulty or misfortune. Stress is a physical, chemical, and emotional factor that causes bodily or mentally tension and can lead to poor health. Toxic stress is a trauma, adversity, a stressor that interrupts the normal developmental trajectory of a child. So we have got to start with children if we're going to start with primary prevention, but we also have to understand what happens to kids who are exposed to trauma. I want to touch base a little bit about adverse childhood experience. It documents the conversion of traumatic emotional experiences in childhood into organic disease later in life.
Rob and Vince then began a collaboration that's ultimately become one of the foremost epidemiologic studies of long-term health impacts of child abuse and neglect.
I think the most important thing that contributes to the information of the ACE study is simply the powerful nature of when people tell you the truth about their lives and you listen, you understand their life course.
It's made me realize how much of what we see in adult medicine is the result of what was present but not seen in pediatrics.
ACE has changed the landscape, and I want to talk a little bit about how and why they changed the landscape and how we can take what we've learned from the ACEs.
It's just not a social worker's problem. It's just not a psychologist's problem. It's not a pediatrician's problem. It's not a juvenile court judge's problem. It's everybody's.
It changed the landscape because of the pervasiveness of the ACEs, the huge number of public health problems, expensive public health problems, depression, substance abuse, sexually transmitted diseases, cancer, heart disease, chronic lung disease, diabetes.
As the ACE score goes up, the likelihood of chronic self-acknowledged chronic depression goes up, so that at ACE score 4 or higher, you're bumping a prevalence of 60%, 60% in women and about 35% in men.
This is the percentage of people that ever smoked cigarettes, and here's the percentage of current smokers. Again, we could switch the titles on these slides now. You wouldn't know which was from the Kaiser Health Plan and which was a general population sample in Washington.
So how do those people without the conventional risk factors end up with coronary disease? We have used this over an 8-year period with 440,000 adult patients.
I believe that this is the most important thing you can ever do, which is begin to deal with this intergenerational transmission of adversity that causes so many problems in our society.
Talk about primary prevention. You can start it with the pregnant couple. You can start it when they have the baby. You can start it when you're talking to their toddlers and their school-age children. You can start it when you're talking to their teens or the elderly. Primary prevention can happen at every stage of a person's life course, because what we are trying to visualize, conceptualize, internalize is that talking about traumas, these conversations, or we call them ACE conversations, really is talking about healthy relationships. A healthy relationship, what's an unhealthy relationship? And these are very important and valuable tools to use when you're talking to patients. Tool, this power and control wheel, was specifically developed when we're talking about domestic violence. On average, half the people sitting in your waiting room have had a significant adversity in childhood. The Utah Department of Health did a study in Utah, and they found similar findings. 63% of Utah adults surveyed said that they had experienced at least one adverse childhood experience. So I can say this with a lot of confidence: half the people we see on average every day have had some significant adversity. The single most significant feature of neurons is that they are designed to change in response to experiences. The second thing is evolution has wired our brains to enhance survival. Our brain has evolved to do one thing and one thing only, and that is to keep us alive. So when you see a funky behavior and you're like, what is that? You have to step back and go, hey, wait a minute. Why is that brain telling that person to do that? How is that helpful to that person? Could this person be someone who experienced trauma? And the last one is behavior seen in traumatized people are normal reactions to abnormal experience. How did this evolution occur? Well, we see that one way is the compartmentalization of our brain structures and functions. And how does the brain get information from our environment? Mostly our senses, and then our threat response. So how does this all come together in our brain? Well, we know that we have the amygdala, the thalamus, hippocampus, and the prefrontal cortex are very important. These are the ones that I need to understand about, because I want to give you information about what's happening in a brain during development. And you can see the little red almond-shaped thing is our amygdala. And the amygdala has been called, it's a very primitive structure. It develops very early in the child's brain. And it has been called the smoke detector. And I think this is a really good way to think about it, because what's very interesting is tactile stimulation and olfactory stimulation go straight to the amygdala. Those two senses are constantly being first sent to the amygdala saying, is it a danger? Is it a threat? Do I need to do something about it? Then your visual and your auditory stimulus go straight to the thalamus, but which just loops right to the amygdala. So those four main senses are going right to the amygdala to say, what do I need to do with this information? And then the hippocampus is very important, short-term memory. And then your prefrontal cortex is what understands what's happening in the context of the amygdala signals, but that comes later. So the amygdala is deciding, what do I got to do? And how does it decide what I got to do? From experience, okay? Before you even know why you are afraid, you are. And all of us have experienced this. When you were growing up, and maybe even later in life, when you get a touch on your shoulder, you get hurt. Then when your colleague touches you and you jump, you don't laugh about it. You say, don't do that again. Don't you touch me again. And your colleague is like, what is your problem, sister? Okay. The essence of the neurobiology of trauma is it is emotional, not logical. Behaviors enhance survival. And why is this important? Because trauma experiences prevent a person from getting to a sense of safety, even when they are safe. Okay. So when you see that behavior you don't understand, you should step back and go, what's the trauma? And why is this such a useful behavior in this person's world? Because this is what they look like when they come into us. They're irritable. They're full of shame. They're full of despair. They don't have hope. They're emotional. They're full of disbelief. This is what we see every single day. If you see somebody's name on your schedule and you go, oh, no, not Mrs. Smith again, and you don't know they got trauma, you've missed it. Because Mrs. Smith, if you're saying, oh, no, not her again, she's probably got it. Every one of these chronic medical problems are found in higher concentration of patients who have been victimized. So get this, understand this, and you should now be able to help your patients heal by this understanding. So when we talk about primary prevention, what should we do? Well, this is where you guys come in. This is where you find things that work. We need to advance the studies to understand this. But one of the things that I think is going to be so crucial is educating young families about the effects of ACEs. But what do you think is going to change their life the most is talking about ACEs. Perry is a psychiatrist who has studied trauma for many, many years. And he has the 6 core strengths of children, which he calls a vaccine against violence. So teaching children about attachment, self-regulation, affiliation, awareness, tolerance, acceptance of differences, respect. If every child had this opportunity to learn that, we would not be having the Black Lives Matter movement, because we would be accepting differences. This would have never been an issue. It's a pattern of controlling, assaultive, or coercive behaviors that may include repeated battery and injury, psychological abuse, sexual assault, social isolation, deprivation, and intimidation. These behaviors are perpetrated by someone who is, was, or wishes to be involved in an intimate or dating relationship with the victim, and it is all about power and control. 42% of homicides in Utah are DV related. 88% of domestic violence perpetrators were male. 22% of cases, children were either involved or witnessed the homicide of their mother. Every year, approximately 80-some children in Utah are witnesses to the murder, attempted murder of their children. Is a nice way to go through talking with a patient when they disclose. The S can be for screening or symptoms. So if you see someone who has symptoms that are suggestive of trauma, and remember, symptoms suggestive of trauma and abuse, especially chronic trauma and abuse, can be chronic medical problems. Hey, maybe this is somebody that I either should screen or I should ask. Or I should have a conversation. We should ask anybody with risk factors for trauma, no matter what, whether it's human trafficking, vulnerable adult abuse, domestic violence, child abuse, sexual violence. This is what we are talking about, is thinking about this in another way. The M is your message. The first message should be, thank you for telling me. I know this was probably difficult for you to tell me about. I believe you and I can help you. That should be the message. Thank you for telling me. And I think this might be contributing to our inability to help you with your chronic headache. So the R is resources, and resources can pull into it the reporting piece. I can give you resources to help you. Here are some resources. And in addition to this, I am going to involve our Department of Family and Child Services, who have other resources they can, or Adult Protective Services, or whatever the case may be, because that's why we do this, is to help them. The T is treat. U.S. Preventive Services Task Force has said, we, who's we? Clinicians. Who are clinicians? Physicians, nurses, nurse practitioners, PAs. We are supposed to screen all women of reproductive age for intimate partner violence victimization, and our policy at the University of Utah says ask anybody with risk factor. This is like scripts to help you formulate your own method of talking to patients.
Talking about social norms in primary prevention of intimate partner violence.
I also want to talk about prevention versus intervention. Kathy did me a great service last week by talking to you about ACEs, because oftentimes I'm charged with going into high schools and colleges to prevent rape and sexual assault. Most people are sexually assaulted before their 18th birthday. Many people experience victimization when they're children, of a variety of different kinds. So while we are trying to do prevention of future harm, we are also always doing some form of intervention, because sexual violence and dating domestic violence, interpersonal violence, is unfortunately a little too commonplace to act as though we can ever truly prevent it, at least in this contemporary time in the short term. I will go into a little bit of differentiation, just like Kathy did about the difference between prevention and intervention, but since she did such a good job, I will differentiate, but know that I'm talking about both and. This is a bit of a soapbox conversation for me. This is one of those things that I want to start screaming from the rooftops. How we think about this and talk about this needs to shift and change. Men's engagement, I'm going to spend a great deal more time saying that's the actual focus we need to have. Jamie said that my title is Men's Engagement Specialist. We actually just changed it about a month ago to Community Engagement Specialist. We did that for a very important reason, because men don't respond when they feel targeted or attacked. They just don't. But when people used to ask me, why is there a Men's Engagement Specialist? What is the reason? Why are you doing that job? I always say, because 98% of rape and sexual assault are perpetrated by men. Now, did I just say that 98% of men rape? I did not. Most men don't. Most men are wonderful, amazing people. Some of my best friends are men. I'm a man myself. So it's not a criticism of men, except to say men make up a grossly disproportionate amount of the people who perpetrate sexual violence, which makes sexual violence and interpersonal violence a men's violence issue, not a women's issue. Now, this is not to say that women and people who are gender variant don't commit acts of sexual violence. They do. And I don't want to minimize that. But there's something going on when 98% of rape and sexual assault is perpetrated by men. And let's say maybe it's as low as 90. That's still something going on with men as a gender or men as an identity. So we'll talk about that in more detail, but that's why my job exists. But men are also impacted to a large extent by this in ways that we don't think about. I often like to point out too, that when men are afraid of their own safety, who are they afraid of? No, men are afraid of other men. So even when men are the targets of violence, they're still afraid of men. So this is the issue. It's a men's violence issue. And if we spent far more time thinking about the perpetrators of this issue instead of the victims of this issue, I think we would do a much better job at preventing it. We talk about prevention of sexual violence. If I said I was going to do a prevention program of sexual violence, things that they're not ready to do, does not work. I got my master's degree in health behavior change, both individual and group health behavior change. And one of the things I learned in that master's program was people don't change their behavior. Okay, that's the problem. That's the issue, is we need to figure out what is the best and most motivating way to get people to start to move this. Some people are going to be ready to talk about this and some aren't. Intent really does. Intending to be racist is different than accidentally being racist. In the end, the impact is the same. There was some racism, but how we have that conversation with a person is pretty important. And a person intending to cause harm, to me, is very different than a person accident. Having a desire to get an intent is really important. And finally, what are our shared goals? I find this to be the most effective thing in the world to go, instead of what do we not have in common, what do we want to do together? What is the shared goal we have in trying to reach an outcome here? Social norms are values, beliefs, and attitudes and behaviors associated with different topics, ideas, people, cultures, customs. So values, beliefs, attitudes, and behaviors. That's how we would define social norms. We all have this idea, are social norms good or bad? What do you think? Anybody think social norms are good or bad? You know, prevention for that kind of behavior can start really early, but usually people wait till something gets really threatening or bad, and that's when it's harder to fix. Let me prove it to you. When I said this to you before, I can prove to you that this binary and gendered thing are real. Let me ask you to do me a favor. In your mind's eye, picture a victim of rape. What does that person look like? What's their age, race, socioeconomic status, gender? Get an image in your brain of that victim of rape. Now think of a perpetrator of rape. What does that person look like? What's their age, race, socioeconomic status, gender? Get an image in your brain of that person. I can't truly do a straw poll here, but let me tell you what actually happened, because I've done this 100 times. How many of you do you think thought, when I said victim, thought of probably all of you, okay? And my guess is many of you said a white woman between the ages of 18 or maybe 16 and 28, okay? When I said perpetrator, how many of you, who did you think of? How many of you thought of a child when I said perpetrator? None of you did, by the way. None of you did, even though we have 3 facilities in the state of Utah for child perpetrators of sexual violence. Now, I'm not suggesting you should be afraid of children. Most of them are not committing acts of sexual violence. However, this is that bias. I bet you thought of the creepiest dude possible. Guess what? That's not accurate either. And actually it is and it isn't, right? Because victims can look like anybody and perpetrators can look like anybody, which makes this a men's violence issue, not a women's issue. That's the problem, that we've been focusing on this as a women's issue when really men can be victims, men can be perpetrators, women can be victims, women can be perpetrators, but there's something going on with the percentage of men who are committing the vast majority of these crimes. And even if it's an isolated group of men, we're going to talk about why, even though men commit the majority of these crimes or are responsible in many cases for them, men as an identity marker, maleness as an identity marker, do not feel accountable or responsible at all. We're going to talk about why that is today too. Just like last time, just like last week, today is the curiosity. Okay, we should have more questions and answers at the end of this. I'm not going to make this easier. It's going to be more complicated. We should have some ideas that are new or at least shifted perspectives on today, and we should begin with some small amount of action steps. Masculinity is neither a good thing or a bad thing. Usually I like to ask this question. We have a big discussion about what's good and what's bad. Not today. Masculinity is a broad-based cultural concept. There are components of maleness. We have long, drawn-out conversations about the difference between gender and sex. We have long conversations about what is maleness or masculine, what is just a concept of masculinity in general, which isn't applied to gender. It's very complicated. And part of the problem here, too, is that when we talk about masculinity, or especially as we talk about violent masculinity or toxic masculinity, some of the terms I'll go through in a few minutes here, we oftentimes men, especially male-identified folks who have not thought a lot about this issue or thought a lot about gendered binaries as being incomplete, they start to equate you saying that maleness is bad or they are bad. But masculinity is neither a good thing or a bad thing. There's great things that come out of masculinity. There's great things that come out of the concepts of femininity. And I'll also tell you, as a person, there are things that I identify as, which men like in general. And again, by the way, I do realize that I'm making these grand sweeping statements about gender in general, but it's important to start thinking about how we started say to me, you can't say anything to women these days. Now that's a silly statement, right? Of course you can say things to women. My point here is that that's how they felt, and how they feel in terms of engagement is actually a critical thing to think about. I don't think we need to remove accountability, but this is where this is. How are you participating knowingly or unknowingly in the problem behavior or in the protective behavior? Remember, we talked about risk and protective factors last time. What are opportunities and protective factors you can bolster? What are opportunities for harm you're actually participating in without knowing it? Are you silently sitting by while somebody slut shames because you say something because you have clout or power in that organization or community or group that could be beneficial? Okay, what are barriers to engagement and what are opportunities to help others? Things to think about. Okay. What doesn't work is you're the accountability and responsibility, like men feeling attacked. And again, this is one of those areas I worry that people are like, you're going easy, you're being too soft on men. I don't feel like that's the goal here. Once men are engaged, you can then start talking about accountability and responsibility in a much deeper way when they feel connected to these issues. Men don't see themselves as part of the violence, so they don't see themselves as connected to it. Men believe many of the social norms and myths surrounding sexual violence, and we can talk about that in general, in terms of like when women drink, they get held accountable, they're responsible for their behavior. When a woman dresses really sexy and flirts, what does she think happens? These are common rape mythology, things that are not true about sexual violence that a lot of people believe that we reinforce culturally and socially. So we're working with people who are inundated with these mythos and these social norms that are problems. Why do we do men's engagement? Because violence harms men more often than it harms women. To be perfectly honest, men are more often harmed by violence than women are in this culture. When we look at statistics and information, the difference though is they're harmed by men too. That like we are all victims of men's violence, and which is why we need to think about this in a broadly different way. So I already said 90% of rapes are perpetrated by men. More than half of all stalking cases are perpetrated by men. Almost all lethal domestic violence and dating violence cases are perpetrated by men. Violence against women is mostly a men's issue. However, there are consequences for masculinity and men in general, which is men's health is poorer than women's. Men die younger than women do. Men take greater risks. Men have greater issues with substance abuse than women do statistically. When we talk about suicide, ideation and suicide, men commit suicide more frequently than women do. So this is one of those things that we need to start thinking about, that understanding that men have a consequence. We need to look at a social norms approach, bystander intervention. I have a new empathy for men's defensiveness. I now have a better understanding of why men might be defensive. I hope you take that away from today. The defensiveness isn't okay, and the accountability needs to be there, but having broadening our empathy for why men might be defensive or why this might be a hard concept for people to immediately grasp. And so how we have to carefully navigate these conversations.
Intimate partner violence is characterized as an unhealthy behavioral pattern of the intent of one partner to coerce, control, and victimize the other partner. It costs the United States $33 billion per year. So even if it does not directly involve us, we don't know anybody that might be a victim of intimate partner violence or sexual violence, we're all affected by it in some realm. 10 billion of that is in direct healthcare costs, and then 23 billion is in production loss. Our victims of violence aren't able to return to the workforce as they normally would, and it really alters their life from that point on. The goal when working with these patients is the safety and well-being of our staff as well as our patients. I put in staff first because these are the dangerous clients. I work downtown at the Level 1 Trauma Center, and these are the cases that worry me that are going to affect our staff, is the angry partner that's going to come and add harm to the rest of our staff as well as the person that they're trying to perpetrate against. Looking at ACE prevention. So again, like I said, when you're working with adult patients, you obviously can't go back in time and take away, their ACE scores, and can start looking at the next generation and breaking that cycle and preventing continuation of these ACE scores from affecting not only IPV and sexual violence, but all those other health problems later on in life. By strengthening economic supports with families, any family-friendly work policies, I think that increases, it helps with job satisfaction, not having a strict family versus work dynamic. Anybody that can feel like that their family is appreciated in the workplace, I think gives a lot to job satisfaction. Change to social norms to support parents about positive parenting. Legislative approaches to reduce corporal punishment. And we're not talking about like a spank or a slap on the hand or whatnot. We're talking about severe beatings with belts and whatnot that they're steering away from. And there's a lot of research that has gone away from that. Public engagement and enhancement campaigns on the dangers of negative reinforcement parenting and really supporting that positive parenting is, I think, a huge. Early education later on, education early in life, you're looking at supporting the teachers in your district, in your area, and supporting that early education. That's not just, giving your kids a good education and the kids in your community, but that is also affecting their health. Providing that preschool enrichment with family engagement and having those, active PTAs and enough finances to have that quality childcare, I think is a huge asset to preventing these adverse scores. Enhancing parenting skills and teaching our parents how to help their kids in the home and not just relying solely on them going to school and learning things. What does that look like at home, and how do you help your child achieve those childhood development milestones in the home? I think is a huge thing as well. Prevent future risk. Obviously, enhanced primary care and access to healthcare is a huge problem for rural areas, especially low-income families, making sure that they are available to receive vaccines. Screenings and these discussions should only happen if the patient is alone. If you absolutely cannot get them alone, this screening should be deferred. And then I would just give them a resource list at the end and just say, these are just community resources. If you ever feel like you need them, please do not screen them in front of anyone, whether it be their partner, their best friend, their cousin, their mom. You don't know who's hurting them at home, and that can actually increase their danger once they get back home. Keep that in mind, that these screenings should only be done, and this conversation should only be had alone with the patient. So this pulls this up. As I said, the HARCS or the SHARC is the screening tool we used. Have you ever been humiliated or emotionally abused by a partner? Have you ever been afraid of a partner? Have you ever been raped or forced to have sex by a partner, kicked, hit, slapped, or hurt by a partner? This is meant to be ever in their life, even if it's not currently, as we're learning that previous abuse can have a direct effect on the relationship. So we like to know if they've ever had a history of it. If they say, no, I'm in a great relationship, say that's wonderful. If you ever need it, please remember that we're here to help you. I love this quote by Nikita Gill. When you ask someone why they stayed when they could have left the heartache and the pain, remember there are days when even you have chosen the hell you know over the hell you don't. So we don't know everything that they're going through. Kind of blame back on the abuser. Why does he or she choose to abuse? It's not our victims, our patient's fault that they are being abused. We need to throw that back on the perpetrator and ask why they're choosing to abuse. What has happened to them that has led them to this? Looking at domestic violence and head injuries. So if IPV victims have more traumatic brain injuries than NFL players, and you look at this article done by Time Magazine saying that 110 of 111 NFL players tested positive for CTE. Almost all of our patients who have had repeated head injuries, whether it be, like I said, anoxic brain injuries from being strangled or blows to the head, that they are probably also positive for CTE. So those of you that aren't familiar, it's chronic traumatic encephalopathy. It's brain atrophy degeneration from being hit in the head or multiple head injuries from that anoxic brain injury as well. Look at the symptoms. And the other one I want to point out is patients with CTE have difficulty planning and carrying out tasks or having that executive function. So when we ask them, like, why do they stay? It may be the case that they don't have the executive function to plan a life outside of that. So red flags, these are very difficult. Most of these red flags are probably you're going to see in extreme abuse situations. Are fearful, they have lack of control, they seem overly submissive to their family member that is there. That's always a red flag for me. And I try to make an excuse to get them out of the room. I take them to the bathroom, take them to radiology, and have kind of a more in-depth conversation with them, making sure that they feel comfortable at home and that they're in a healthy relationship. At least give them the opportunity to disclose if they would like to. Obviously, any evidence of abuse, if they're accompanied by a controlling person, keep in mind security. No one has a right to be in your facility. So if there's somebody that's causing problems, we can be the bad guy and we can keep that controlling person away from that patient and really kind of be able to keep that patient safe. Inconsistent history, whether that be from, their trauma brain and they're unable to kind of tell you what happened, or if the story doesn't match the injury, we all know that's a red flag. If they seem to be in a rush to get out, as I mentioned, my patient had to be home at a certain time, otherwise she was going to get in a lot of trouble. If they're constantly on their cell phones, if they have their cell phone in the lap, be aware that your patient's abuser may be listening in on your conversation. So put cell phones away, make sure that they're not sitting out in the open. They may be recording your conversation. Just keep that in mind that is something that abusers tend to use. This in here just to remind you that nobody experiences trauma in the same way as another person. I could have a traumatic event and I could have that startle response. I could have nightmares and flashbacks, where another person might dissociate completely, have a loss of interest in everything, and just become very flat with self-destructive behaviors. It just depends. It's all completely 100% normal. And no one is going to have the same response. Take the few minutes out of your day. I understand that a lot of you work in emergency departments and you might not feel like you have the time take the time to have this conversation with the patients. It's very important for their health and for it can keep them alive. Know your resources at your facility and your community. Know where to send them if they do disclose that they've been abused by somebody. Know what resources are available. Do you have a caseworker in your facility that you can kind of point them to, or a crisis worker that can give them resources and have that more in-depth conversation? The YWCA has great resources with the Family Justice Center for patients who are experiencing intimate partner violence or sexual violence. Something that is very important once you start screening patients for intimate partner and sexual violence is to kind of be consistent throughout your staff. So I'm hoping that we can be consistent and kind of get that scripted dialogue so that everybody has the opportunity. Educate and empower your patients to seek healthy relationships, have these blunt, frank conversations with them. It helps them understand that they're not alone in their situation and that there is a healthy relationship and a healthy path for them going forward. Know how to build your safety plan, not only for your patients, but have one for your staff as well. Know your panic buttons, how to contact PD or security to keep everyone safe, because these are the volatile cases. Something that we really want to talk about in this, the important part is how we present these topics to our patients. And language absolutely matters. Whether you are talking with your patient in an interview and collecting history, or whether you're documenting is also important, because a lot of these are criminal cases and become public record afterwards. Anything that you chart in this becomes public record. And the victim or patient does end up getting to see what you chart about them. So keep that in mind when you're charting. And then just conversations you're having, maybe you think that is not within earshot of the patient, but is actually something that they are hearing. Sometimes we are not as quiet as we think we are when we're standing out at the desk. So be aware of what you're saying and how you're saying it when you're talking to ancillary services, law enforcement, things like that. Go back to that start by believing, give them the benefit of the doubt at the very least, and help them move forward from this. So we want to use sensory-based questions rather than fact-based questions. And that goes back to a trauma-informed, the neurobiology of trauma. Our memories are stored, and not in a normal fashion, but they're usually linked to our senses. So what do you remember hearing? What do you remember smelling? What do you remember tasting? Can help elicit information that if our patients who are maybe triggered by a recent assault or past history of assault, and we were trying to talk to them about things, that can be very helpful. Be aware of potential triggers, especially if you are familiar with this patient. Think about what situations or things around might trigger them. It might be a sound, it might be cologne, it might be something that you're wearing. So if you are familiar with this patient, be aware of their potential triggers and how to best kind of mitigate that. If you're not aware of this patient and you don't really know their history, listen to what they're telling you and try to be aware of, use the grounding-based questions. If you feel like you're talking to your patient and they've kind of zoned out or they're not here with you again, and this can be in any sort of discussion, you can bring them back to the conversation by just asking them a simple question that they need to talk about. Find a quiet environment to discuss details. I really encourage our staff to bring our patients back to a quiet environment, sit down with them, get on their level and allow them to kind of talk about the details that way. Allow for gaps in memory. Remember, a lot of these scenarios go back to the neurobiology of trauma, and we're not storing memories as we normally would. So allowing for those gaps, letting them know that it's okay that they don't remember everything right now. My favorite 3 phrases that I use all the time when I'm doing my forensics work and interviewing my patients is, do you recall? This allows for that ability for them not to remember, and lets them know that it's okay if they don't remember. Or what do you remember about? And then if they say something that I need more information about, tell me more about what you mean by that. And I use this all the time in interviewing my patients, particularly in triage. They come to the window and they say, I'm sick today. Tell me more about what you mean by you're sick today. Can really allow for them, and it's a very non-judgmental way to elicit more information. Generally, what doesn't work is these sequential questions: who, what, where, when, and why. We really like those questions in our fast-paced environment, and particularly when I do training for law enforcement. Getting them out of that rapid fire systematic questioning is very helpful when talking about patients who have been affected by trauma in any form. Something that I really want to highlight is avoid the use of victim blaming language. Get rid of the word alleged. We're really working hard in our documentation at the U to get rid of that word, remove it from our chief complaint so it doesn't say alleged sexual assault, alleged domestic violence. Please don't use it in your charting. Again, if this becomes public record, it just implies that you didn't necessarily believe them. I like to use the word reported. It's, again, a completely non-biased. We're not siding with the victim. We're not siding with the perpetrator. We're just saying, the patient came and they reported abdominal pain. The patient came and reported that they were assaulted. A lot gentler, and allows for that. Start by believing philosophy. I hate the phrase "did you," particularly when talking about assaults. That's why I like to go with "do you recall this happening?" By using the word "did you," it implies that, well, did you really do enough to prevent your assault? Did you really do enough to prevent this type of abuse that you are experiencing? Avoid how your language might come across when talking to our patient. Please try to avoid using the shared responsibility or consensual language. If a patient was raped orally, she did not perform oral sex on the suspect, or she did not perform oral sex on her boyfriend or her husband. That was a rape. Please be aware of what you're trying to be aware of, how you're speaking. It really does matter, and a lot more comes across as victim blaming than you might think. So have these conversations ahead of time. Feedback saying, that probably wasn't the best way to say it, and really strategize on what comes on what can be a little bit softer approach with these types of patients.
This starts to outline the mandatory reporting for healthcare providers. You're a person, corporation, association, which furnishes treatment or care to persons who have suffered bodily injury. So all of these people fall into category of mandatory reporters. So bodily injury, like a wound or other injury inflicted by a person's own act or an act of another by means of a knife, gun, pistol, explosive, infernal device, or deadly weapon, or by violation of any criminal statute of this state. This is the part of the code. So it's lawmaker lingo. The way we break it down, injury due to assault, right? So if there is an injury due to an assault, any wound or injury inflicted by their own act or an act of another person, breaks down to is, if a patient is being treated for an injury due to physical or sexual assault, or has been threatened with a lethal weapon, the mandatory reporting law for healthcare providers is call police. Other part of that is if children were present during the assault, or if patient is a minor or vulnerable adult, we also must report to DCFS or that Adult Protective Services. Children are witnesses to intimate partner violence or domestic violence. That is a mandatory reporting piece for child abuse. It's considered child abuse in terms of Utah law as well. It's not a violation of HIPAA if that's ever a concern that comes up. The cautionary piece, it's just for intimate partner violence. So when you have to make a report to law enforcement, determine the jurisdiction where the injury occurred, right? This is what you're going to let them know, right? The report shall state the name and address of the injured person, the injured person's whereabouts, the character and extent of the person's injuries, and the name, address, and telephone number of the person making the report. So that's you. So give them your info. You want to document for yourself what law enforcement agency, LE, what time and phone number did you call? Who did you speak with? What's the name of the officer or dispatch who you connected with? And did you get a case number that was assigned? There should always be a case number that was assigned. Best practices of having these conversations with patients and communicating with patients about intimate partner violence and your reporting requirements, prevention strategies for you within that communication and your agency workplace facilities overall. When we're talking about prevention and primary prevention, we're looking at prevent disease or injury right before it occurs. So we're doing something that's going to intervene or change the trajectory or the culture of a society or environment. And there's lots of ways that we address primary prevention and can make that happen. Goals of primary prevention, how can you participate in prevention strategies, right? What could you do to improve resilience? Primary prevention through patient interactions and policy are really key to incorporating, this and understanding how healthcare providers can, not just be responding to actors in primary prevention, but the ways that you engage with patients and the conversations you're having with them and the information you're sharing, the compassion you're showing them, that's increasing primary prevention within within those interactions that patients will continue to utilize. So that behavior you are modeling is improving their safety and protective policies in all of our work everywhere, right? Those are things at an institutional level, organizational level, or just around a certain area that you're responding to. So are there policies that are going to help healthcare providers or institutions recognize and respond to intimate partner violence? With creating strong policies and having proper follow through with them, that's how we create prevention strategies really with bigger picture level. When we're bringing in policies, procedures within your organization, this is about the culture of your workplace, the environment there, and what does that look like? Institutions are pretty powerful and do have a lot of ability to sway and set and reinforce norms, positive or negative ones. So I would ask and suggest, consider where you work, your office, in your clinic, on your floor, wherever you are, what's the culture there? Are there stereotypes that are reinforced? Are there harmful things that go on that are deemed okay? That's not a big deal to have sort of behavior that might not be healthy or appropriate or professional even. What does that look like? And how is that culture further maybe playing into gender stereotype oppressive systems for anyone, right? Whether they're victim, survivor, or never experienced abuse, and how are interactions between staff, right? What are your communications looking like? Because people who are visiting and patients are watching that and checking out what you all are doing. Other pieces that are important to do is talking with that patient and that person about what's going to happen and what does it mean for their safety and the next few days if police are involved. If the person that's hurting them knows that police are now involved. And this can be when it becomes important to engage in some safety planning. Be prepared with resources. If you're making a mandatory report, or even if you're not, if they tell you that they've experienced abuse in their relationship, but they're not seeing you right now for an assaultive injury, right? You don't have to report that, but you should be providing resources, making referrals. Safety planning it's a plan. It's personalized for every person who's getting it, and it's something you can use in practice, right? And it's going to include ways to remain safe while in the relationship, if you're planning to leave a relationship, or after they leave. Now, it's not just for victims and survivors, but like if you would like help with a safety plan for yourself in terms of, I want to know how to safety plan with someone, speaking with the patient about what they're experiencing is already supportive in preventing further violence. Your communication and your recognizing that there's violence occurring is the crucial first step. But what you can do is call on experts in your workplace. Is there someone in your office? Is there a social worker who is specifically there to help with these sorts of cases that you would call and say, can you come down and do a safety plan, or can we set them up with a follow-up appointment with you? So there's agencies within the community you could call for immediate support as well for safety planning, and who would know direct resources that are going to be most applicable to that person. So you don't have to know it all, but if you know who to ask.
Most victims, when they initially disclose sexual assault or domestic violence, they go to a friend or a family member before they make a formal report or before they seek medical attention. Discuss this kind of throughout, but that response from that friend and family member is often the most critical response that the survivor will receive. Because let's say a 16-year-old child tells their mom that they've been sexually assaulted while they were at a party. And if mom responds with, well, what did you think would happen if you were out drinking? That 16-year-old probably isn't going to tell anyone else. They're probably not going to make a report. They're just going to attempt to move on their own. So we really need to make sure that friends and family members have a supportive response. And you can see these statistics here. I don't need to read them exclusively to you, but less than 20% of survivors report to law enforcement, and less than 40% of survivors will seek medical care. So in order to get survivors to the place where they feel like they can access medical care or that police report, we need to make sure that they have a supportive first response. We also know that when a survivor reaches out to one professional support, they are more likely to reach out to others. For example, let's say a survivor presents in an emergency department for injuries related to domestic violence or for a forensic exam after a sexual assault. That one contact, if positive, can increase the likelihood that they will file a police report. It also increases the likelihood that they will connect with an advocate or call a crisis line for support. So as you can see, that first response increases the likelihood that they will engage with others. And that's ultimately what we want. We want them to come to us for help and support. Now, I want to talk a little bit about what happens when the reaction to their disclosure is negative. We know that the negative reaction reduces the likelihood that they will tell anyone else, as I mentioned, and it also increases the likelihood that they have more harmful health and healing outcomes. Increases in post-traumatic stress, increases in suicide ideation, increases in alcohol abuse, drug abuse, any form of substance abuse. We know that having that harmful reaction really sets them up for failure in terms of their healing. And we know that they're less likely to tell others in the future. And I'm going to share a little story with you. Sam is a sexual assault survivor and she's a forensic nurse. And we met in December. And during that interview, she told me that she didn't tell anyone when she experienced a sexual assault because when she was the victim of an attempted sexual assault in high school, she was blamed for it. And she was told that it was her fault. And she actually watched all of her friends side with the perpetrator. So she knew that she was likely to get another negative reaction, and she was too afraid to tell anyone for fear of being blamed or for fear of not being believed. And she specifically said that she became a forensic nurse because she didn't want anybody else to experience what she had experienced. With you, Elizabeth's story. Elizabeth is another survivor that I met with. We met in January, and she was sexually abused as a child by her father. She tried to tell as a child in a child's way that something had happened to her. And it wasn't until she was an adult that she told her mother that she was sexually abused by her father. And her mother's response was, "I believe you believe something happened to you." So her mother did not fully acknowledge that she believed Elizabeth until many years after that. Her mother had attended kind of a self-help awareness presentation and returned to Elizabeth and said, "I'm so sorry, I do believe you." When Elizabeth was a teenager and she told her parents she was sexually assaulted, she was told he didn't mean anything by it and it was an accident. And after those two experiences, by the time she was sexually assaulted when she was in the military, she told me she didn't bother to tell anyone because she knew that she wasn't meant to be believed. Elizabeth then attempted suicide 3 different times. The third time, waking up in a hospital room, she knew that she needed significant help. At that point, she reached out for counseling. She thought she had moved forward in her recovery. She thought she had healed from it. And then she experienced a number of triggers in 2017 and 2018 that kind of brought everything back for her. And she revisited counseling, and she actually started working as a volunteer for a rape crisis program, sharing her personal story. And her ability to share her story and find her voice has really allowed her to heal further and embracing the knowledge that she truly experienced violence across the lifespan. And so when we look at that violence across the lifespan, if we go back to when she was a child, if she had been believed from the very beginning when she tried to reach out, or if she had been believed as a teenager, it's possible that the subsequent assaults might never have happened. So that's how we can look at this as primary prevention. It's also important to point out that it might be more beneficial to receive no support at all than to get a negative response. And this one, whenever I see this slide, it's always so compelling to me. No support at all. So being all on your own could be better than getting a negative response. The rate of false reporting in terms of sexual assault is very, very low. The studies coalesce around 2 to 8% are false reports, not coalesce, converge at around 2 to 8% are false reports. So again, it's very low. Most survivors are telling the truth. This doesn't mean survivors tell the truth on every single detail, but it does mean that they're most likely telling the truth. And that's part of why Start by Believing is so important. Rather than doubting survivor stories, it seeks to respond to every report as though it has merit. Start from that orientation that the survivor is telling the truth. Survivors need to be believed. They need to be told by their loved ones, their friends, their family members, that they believe them, that they hear them, that they see them, that they want to help them. So that feeling of being believed bolsters their ability to heal and participate if that's something they want to pursue. Survivors need to be validated for their experience. They also need to have someone to talk to when they want to talk to someone. And one other thing that I want to be really clear about is that survivors also need to be supported, not told what to do. So often when we have a survivor of sexual assault or domestic violence, as a responding professional, our response is, you need to report, you need to do this, you need to do that. And these are the steps from A to Z of all the things that you need to do. And we really need to take a step back and present that as, here are your options. Here are the things that you can do. If they present at an emergency department for a medical forensic exam after a sexual assault, simply explaining the process and then asking along the way if you have permission to proceed can be tremendously empowering to them. I remember clearly training advocates on how to talk with a survivor about whether or not the survivor wants to report, and being very mindful of never saying, you need to report this, it's so important, you don't want other survivors to come after you. We just need to be very careful with the language that we use so they don't feel that there's pressure after they've just had all of their power and control taken away from them.
My name is Nicole Rabb. I am 30 years old. I am a nurse. I am a Paralympic snowboarder. I am a daughter. I am a friend. And I am a domestic violence victim survivor. I use the word survivor because not only did I survive my attack, but I thrive today. The reason why I thrive today is because of programs like this and because of family and friends who believed every word that I said.
A little background on Nicole. Nicole was in an abusive relationship, emotionally abusive relationship for 6 years. When she tried to leave the relationship, her partner stalked her and he tracked her down into a new apartment and he shot her with a shotgun at close range 3 times. She nearly died. She was immediately taken to the hospital. She had multiple surgeries. She lost her hand, which is why she's now a Paralympic snowboarder. And the perpetrator died by suicide 3 days later. She has a website and it's called One Handed Nick, and it's pretty fantastic.
Meeting people where they are versus holding people accountable. So I see very often that we talk about cancel culture today, and people have a variety of different reactions and feelings about cancel culture and how horrible or wonderful or evil or great it is. And what I would say is I once heard the term, instead of calling people out for doing things that are culturally, socially, interpersonally inappropriate, what we should be doing is calling people in. And this is a really important idea to me that I hope we can start incorporating in great ways. When somebody does something or says something or acts in a way you think is inappropriate or wrong-headed or not healthy, how could you call that person, invite that person into a conversation about making these things healthier? Or how could you invite them to resources instead of condemning them for the behavior or the problem? Does that make sense? Hopefully it does. That idea, I think, is really valuable. And I will also tie this into just behavior change theory and research on behavior change, that some people respond to negative reinforcement. I don't want to say nobody does, but far more people respond to to positive reinforcement and support. Just like Start by Believing is a great example of this, that instead of asking a person why they got themselves into this situation, we start by saying, oh, you need help and support because you feel something bad happened to you, let's do that. You can see why all of a sudden the data will show a person's recovery is faster, their ability to readapt and reacquaint into normal everyday life is faster. So what we want to do is say, like, there is a component of this that we need to think about related to how do we invite people into this instead of challenging people for not doing it perfectly. Have an empathy for defensiveness. And this rolls into a lot of the work I do related to men and men's engagement. But we right now, and by the way, I think that the hostility and anger and is righteous associated with histories of sexism, of racism, of homophobia, of trans, all of the feelings come from places of very righteous anger. But understanding that when a person is defensive, it's often because they don't understand or don't know how to change behavior or don't know how to fix it. So I actually got this term from a victim advocate at Hill Air Force Base who, after talking, we did a presentation on men's accountability, and she said, I have a deeper empathy for men's defensiveness now. I think I understand it better. And to me, that's the whole point of that call-in idea. If we understand where their defensiveness is coming from, we don't take it personally and we can actually start moving forward. And really, oftentimes that defensiveness isn't directed at you. It's a response to feeling cornered or feeling responsible. So hopefully that idea makes sense, but just something to think about, that if we have an empathy for defensiveness instead of a reactivity for it, we can move a conversation along. Vulnerability is an action, is a behavior. We sometimes see vulnerability as as a passive thing. It actually is a very active idea. Being vulnerable means stepping into some of these uncomfortable places. So that means for us, and it also means for the people we're trying to talk to about these issues, whether it's a patient, whether it's a patient's family member who's responding poorly to ideas and facts about interpersonal violence. Thinking about kindness as a radical act. I think that's something we all need to think about as we move forward in this field. Understanding that privilege is structural and societal, not individual. Now I put the word sometimes there because sometimes people can exercise privilege in really unhealthy, inappropriate individual ways. But understanding that the concepts of male privilege, white privilege, able-bodied privilege, these are structural and societal ideas, and so how they are experienced. And we'll talk about this as well, because privilege is is often unobserved and unexperienced by the people who adopt privileged identities. That is a very complicated thing. So oftentimes too, when I see people throw around you're exercising your privilege, or you're totally privileged, and a person says, I don't feel privileged, I have a lot of really hard things in my life, we have a disconnect there instead of trying to find a place of meaning and moving forward. When we talk about what vulnerability is and why vulnerability is important, I'm going to challenge you all and say that vulnerability is not just important for the people who we're working with, our patients, our community members, the people we're trying to educate. It's important for us. And we all, as people talking about interpersonal violence, prevention, intervention, or treatment, or support, need to be thinking about how we are using vulnerability in a good or healthy way, or how we're using it in an unhealthy way. And being vulnerable, using vulnerability versus being vulnerable or being in a place to be harmed by it. Again, just some ideas to think about. So what doesn't work when we're talking about how to bring and invite people into these kinds of conversations? So you're the issue, accountability, and responsibility. So saying that you're the problem or you're the issue is not a really helpful or effective way for most people to invite them into these conversations. When people feel attacked, targeted, or labeled, they do not tend to respond in a place where they want to continue to invite ideas or dialogue. So this is an area where we need to start to think about this. Now I'll tell you, I was doing a presentation similar to this or on this topic once for a bunch of victim advocates, and they got very angry at this slide in particular, where they said, but what about the people who are perpetrating these ideas, these notions, these frameworks? Like, shouldn't they be held accountable? And I said, yes, they should. But if we are and on an individual basis, if my friends, family, or people on an individual dialoguing basis say some of these things, I challenge it immediately. And I think it's important to figure out ways to have those kinds of conversations. But when we understand that sometimes these issues are broader or more structural, how do we get people to move along? Because one of the things I want to throw out to you all as an idea is one of the curses and benefits of having privileged identities or experiencing privilege in society is that I get to turn this off when I want to. So if I have white male privilege, which I would identify as I do, and someone challenges me with the notion of gender discrimination or talks to me about the different cultural norms related to sex and sexual safety, I could just say, you're wrong, and walk away because privilege allows me to not have to think about this or encounter it for the most part. So what I would want to do is, although it feels like in some ways we're letting folks off the hook, trying to figure out how to keep people engaged in that conversation and figure out ways to have them identify being a part of this or being a component of the solution to these problems, but keeping them involved in the work in that community or in that family or in that society is a much better approach. So understand too that people believe many of the social norms and myths surrounding sexual violence too. So although we are in a place now that's very different than we were 20, 30, or 40 years ago in our understanding on victimization and perpetration and what constitutes sexual harassment or sexual assault or rape, we have I would say the work of many, mostly women, but many women and men and people in general over the last few years is important, but understanding that like that culture change and cultural change attitudes move slower than a lot of other things, so that we still have some of these myths culturally and socially normalized. And again, whenever people ask me what does that mean or how do I know that, I always say, even contemporarily, if you can find me a TV commercial with a man doing housework, either cleaning or vacuuming or doing dishes, that doesn't have that as a major component to like, look at this man doing housework, I would be very surprised. I have almost never seen that. Still in 2021, that we see women as homemakers. This is something that has been habitually normalized, and even to the extent that like we know men do more than that in terms of housework in the homes, but when they're selling products, we still normalize it that way. This is one of those areas that like, even though it's silly to think of women as doing that work. And by the way, I do also rationalize that women still do the bulk of the heavy lifting when it comes to parenting and housework statistically. This is also part of that problem. And by the way, this is also I use this, as I'm saying this example, I'm thinking COVID-19 is even more profound as we start to think about these issues, because not only was that burden already greater when our governments asked us to keep our children at home, and then we needed to do childcare, probably still work from home if we could. Many people had to work outside the home, but those obligations doubled, tripled, and quadrupled, which thinking about that impact on their health and safety is really critical. And then if we could start to think about intersectionality and how that relates to domestic violence or sexual violence within the home, it gets very complicated. Okay, I went off on a weird tangent there, but anyway, let's see. Okay, so I just want to start to point out, and I'm not going to go into this example in too much detail, but just say that the victim-centered versus trauma-informed versus perpetrator prevention, that we are moving towards a victim-centered and trauma-informed approach to how we deal with interpersonal violence. These are both very good things. They are very, very important things. But we also need to start a very uncomfortable conversation about perpetrator prevention. Perpetrator prevention is better than perpetrator intervention, which we have a lot of data, resources, organizations, and groups that work with perpetrator intervention, especially as it relates to domestic violence, and then to some degree when it relates to sexual violence. But we also need to start to talk about what perpetrator prevention looks like in that little triangle of victim-centered and trauma-informed, because perpetrator prevention should be an equal part of that, to try and move towards understanding what are risk factors to perpetration, what are preventive factors to preventing perpetration. But we often don't like talking about perpetrators. We like that binary of like, someone who commits an act of sexual violence is a monster and they're awful and they're terrible. Perceptions encourage people to believe those kinds of false norms. And so what we want to do is challenge those misperceptions and teach what is correct, because most people will do the healthy or right thing when faced with those opportunities. So really important to think about. Individuals will, correcting misperceptions allows individuals to correct those beliefs. Sorry, you all, your pictures are covering the bottom of my slide, so I was paraphrasing. Okay. What does accountability look like for us moving forward in this when it comes to education, when it comes to intervention? And what would accountability look like for violence in a just world where we started really holding people accountable for violence? So again, that would look like bystander intervention trainings, which I'd like to see a lot more of. I think bystander intervention offers us opportunities to really challenge not just some of the problematic behavior related to sexual and interpersonal violence, but also related to those precursors to interpersonal violence, the sexist language, the inappropriate reactions to people's faiths, so anti-Semitic comments or anti-Muslim comments or anti-Christian, all of these are problems. And bystander intervention offers us a path to start addressing those on a cultural and social level and even more broadly. I will also say I like the idea of using a strength-based approach. We have to define what is healthy if we're going to start talking about what isn't healthy. We have to educate on what is healthy. If we're going to educate on what's not healthy, we have to start talking and using research on what's healthy, doing research on what's healthy and what's not. This begins to be a real big problem that we have to, one of my favorite frames for this was somebody once said to me in a training, you can't do a don't. You can tell people not to use drugs. Absolutely. Although, again, that answer gets very complicated. But you can say, don't underage drink, but you then have to talk about what is, when they hit 21, what is technically considered appropriate or healthy or community standard behavior, or what is considered healthy by our community, or et cetera. But you have to talk about these kinds of things, because just giving someone a reason to not do something isn't enough. It's not useful, especially as they start to navigate some of the more culturally tricky issues associated with adolescence and even adulthood. Understanding risk and protective factors and figuring out what those things are, and actually doing research to collect those kinds of things. What are risk factors for violence in our community? What are protective factors within our community, and how do we enhance and support those? One of the things I often think about is community connectedness, and I think, how do we make sure we're doing that in all parts of our community? What does that look like, and what's our accountability? I also just want to say, as we talk about accountability earlier, let me just say that it's interesting to me. I said to a friend the other day, and again, I told you a minute ago, I live in Salt Lake City, and we have a fairly significant issue with homelessness right now in the city. And I said, if everybody in Salt Lake, or everybody in Salt Lake County, or everybody in Utah, every time they saw one homeless person, felt a level of obligation to fix that problem, I think we would solve this a lot sooner. Instead of normalizing and looking at folks who are experiencing homelessness, even though there's a variety of complex reasons homelessness happens to a variety of people, including, by the way, domestic violence, escaping a home and live. We have an unfortunate number of mothers and probably fathers living in their cars with their kids to escape violent relationships, that you start to see, like, how do we look at this as anything that's affecting members of community are part of our accountability? That, to me, it takes work and takes some personal, social, and political capital to start to address.
Coercion has really been informed by the reproductive coercion scale that was developed by Elizabeth Miller in 2010, based on her investigator experience as an adolescent medicine provider. Well, I think that this has been really helpful to have a standardized scale to provide some pretty homogeneous data for a novel and kind of nascent field. There are some things that I think you might notice if you all are familiar with intimate partner violence screening tools that are a little bit different, and that potentially are things that might be changed about this scale in the future. Mostly like this kind of idea of intent. There's a lot of focus here on condom manipulation, but regardless, this has been amazing and really helping generate a field around reproductive coercion. And the reason why I introduce it is because it's echoed throughout the quantitative data that we have, including like here, what we understand is like the tactics that are the most common. These are directly pulled from Miller's later studies, and many other researchers have used this scale as well. And so we see that some of the most common things that folks are reporting is that their partner is telling them not to use contraception or threatening them and kind of pressuring towards pregnancy. For reproductive coercion specifically, so at in this one study by Clark, this is a Clark study, 16% of folks who were just showing up for like their pap smear, like just showing up for routine OB-GYN care, reported prior reproductive coercion. And that's what that scale that we introduced at the beginning here, that may also be underrepresenting how many people are affected just because of some of the things that I think can be modified in that scale. So that's a lot of people who are just coming in for sexual and reproductive health care. This range is also really broad based on the setting. So 10% is from a 2-question CDC-based national survey that I think probably underrepresents based on just asking only these 2 questions. And then 75% is asking people at a domestic violence shelter. So a lot of people who are there for physical or sexual violence are also going to be reporting reproductive coercion as well. Like I said, there are mixed demographic associations with IPV as there are with reproductive coercion, and really thinking that even though we want to recognize those who are at higher risk or more vulnerable, that as providers or folks who work in a healthcare setting, that universal screening is what's recommended and is most likely to convey the sort of education and support that we want to around violence against gender-based violence. And then this association with IPV, other tactics. So this kind of varies based on the study, but and it's kind of unclear, I think, at this point in terms of our understanding of reproductive coercion. But if you look cross-sectionally, like in one moment of time, people who report physical and sexual violence, about 50% of them also report reproductive coercion tactics. And if you followed this people longitudinally, I don't know if all of them would say yes to both, but we know that in identifying someone who's affected by reproductive coercion, we're identifying someone who's at risk, significant risk of other forms of physical or sexual or emotional violence. There's a place for us to recognize and address violence in the work that we do. It would start with acknowledging that violence is a major contributor to premature death, disability, and injury. And I think that's our primary task as healthcare providers, is to reduce anything that contributes to those ends. And I think it also is worthy to consider that violence is preventable, that it's not an inevitable part of our lives, but that it's something that truly there is hope and evidence that primary prevention is real and can take traction. And some of the things that folks have really looked into in trying to demonstrate that point, that I'm not an expert on, but have borrowed generously from a lot of violence work, is around temporal trends. So in looking at homicides over time in the US, why is it that there was such enormous variations in homicide rates over time, or by geography? So looking at Salt Lake City does not make it into the top, whatever this is, 40 something. I think we're 49. There's a lot of geographical differences. And these sort of, this inspection of data really was part of a trend within folks who study violence away from thinking about reactionary punitive measures to address violence towards a prevention-based measure with policies situated in scientific evidence. So I think it's also really good to know like what's going on in your state and your community. So, and interestingly, these are the FBI data from this year from Utah, that while Utah has lower reported rates of all violent crimes, there are higher, this is just a change of definition here, higher rates of reported rape. I think that there's really complicated theories around why this might happen, but that, and why these trends are happening, but that what we can do is use this model that's been really effective at things like car safety and like smoking reduction, to think about how we think about violence. And by having surveillance networks that allow us to collect robust data and to bring legitimacy to the role of violence in healthcare, we can start to create measures that are focused on effective and sustainable primary prevention. And that really started in terms of like a very truncated history of like actually addressing violence in healthcare, that you can go to the CDC and see this timeline, but really started in 1979 when the Surgeon General identified violence as a healthcare priority. And then the development of some really important surveillance networks to collect data, which prompted some standardized definitions around what are we actually talking about here, what are we measuring. Big times in 1994 with the Violence Against Women Act that really provided some dedicated funding to the creation of special forensic teams, prosecutors, the creation of a survey, a national survey. And now more recently, we're starting to see things like publications around effective measures to reduce dating violence in high school settings. So that is 2 years ago. So this is all like pretty novel, but exciting. And I think is really the future of what we need to look at in terms of research on violence is how can we not just measure prevalence or incidence or demographic associations, but how can we measure effective and lasting primary prevention models? And it's starting, I think, here. This idea, if you can stick with me for, I actually don't know how we are doing in time. Woo, we're doing okay. But last kind of major point about violence is that gender-based violence is unique in that it affects such a large percentage of those who identify as women. It affects them in every aspect of their life. It frequently involves sexual offenses and is primarily committed by a known perpetrator. So those are things that I think are so powerful in understanding how to interpret the impact of intimate partner violence and reproductive coercion. And so examples of this, I think, include figures that show that most homicides of women are committed by intimate partners, or that there's no place that is safe for women from these threats. So the leading cause of fatal occupational injury for women is homicide, or that may not even feel safe to be at school. And we know that very intimately here at the University of Utah. And I think despite some few highly publicized events, we're routinely kind of blinded to the prevalence and dynamics of violence against women. And so this is a really typical headline referring to a beloved member of our community who was killed by her partner. And this kind of idea of being shocked and disbelief is this classic, I think, homage to the invisibility of the issue. And there's no mention of intimate partner violence in the title. So I've done this talk in like 4 or 5 different cities, and I can find headlines that are the primary headlines that really don't mention what happened, what are we naming, and how can we publicly acknowledge what were the forces at work here. But it's not, that's kind of not part of the public eye. But there have been more recent efforts, I think most notably with the Me Too movement, that have allowed the burden of these lived experiences of women to come to our collective consciousness. This was a movement that was started by civil rights activist Tarana Burke in 2007 and then popularized by social media largely in the last 3 years, with data from Facebook now showing that over 50% of users have had one or more friend post Me Too. And so these anecdotal, I think, data from our own lives or from our social media accounts is now also, I think, being legitimized by other studies. So this is from University of California in San Diego Center on Gender Equity and Health shows that 81% of women report experiencing sexual harassment and assault. And so in this sense, I think that, and why I've spent a lot of time on this slide, is because I think it's important that we begin to understand that violence affects us all, but that those who identify as women are affected in a very particular way. And the intimacy and gender-based nature of these offenses may be impossible to separate from worldview, from notions of justice, from health-seeking behaviors, from core identities. And so it's illustrating to me the centrality of this topic to the work that we do as leaders in healthcare settings. To go into this somewhat briefly, this is basically showing that this was in college-aged women, folks who showed up for 2 or more STI tests in the last 3 months, or showed up for 1 or 2 more, the asterisk being that it was statistically significant. folks who are showing up for more pregnancy testing or STI testing were significantly more likely to report ongoing reproductive coercion. Kind of makes sense. I would call this as an important moment to recognize this as individuals engaging in a resistance strategy rather than thinking like, gosh, what a waste of healthcare resources to us as people who are involved in the care of individuals. If we notice this, to think, gosh, why are they misusing healthcare? And think more deeply around what might be shaping folks' presentation for care, and this really important opportunity to ask more about what's going on behind these behaviors. For a lot of clinicians is that, and I think healthcare providers in general, people involved in the healthcare community, is I do not want to ask about intimate partner violence because I was not specifically trained to do that. And why does it, like, it always is just me asking and then referring somewhere else. And it's me collecting data to then give someone else work that is beyond what I do. I would argue with something as important as recognizing violence, it's okay if you're not the person who's responding directly to that, you're kind of creating space to create a referral. That's an amazing way you can change someone's life. But also with specifically reproductive coercion, and I hope in the future as we get kind of more ideas around primary prevention and kind of more robust data around secondary prevention for intimate partner violence at large, is that the healthcare setting is also the locus for responding. And I'm going to make that argument right now for reproductive coercion. I think starting with, in terms of primary prevention, is that screening is actually not an effort to promote disclosure as much as we feel like, are we going to get a yes? Are we going to get a no? It actually doesn't matter, because what it is doing is it's signaling to your patients that this is something that you care about, and it's providing universal education around phenomena that we recognize in the healthcare community as things that are important and affect people's health. And so I think really just holding on that in screening, we're actually providing critical information about healthy relationships, to me is what motivates me to ask every single time that I see a patient. But anyway, we've kind of created this idea, and OB-GYNs are the best at it, I will put, the best at universal screening for intimate partner violence, but a lot of primary care providers have gotten very good about integrating intimate partner violence into assessment into their work. And I would argue that because there's this incomplete overlap between reproductive coercion and intimate partner violence, and because there's very distinct sequelae for reproductive and sexual health outcomes, that it's worth specifically asking about reproductive coercion. But in doing so in a trauma-informed way and in a way where we recognize experts as survivors as experts, we have to recognize our mandated reporting status and really clearly disclose the limits to our confidentiality, so we aren't trapping folks in a situation where we then make a report that they weren't intending on, and potentially undermine their safety in that sense, but also really severely undermine their relationship with the healthcare community and kind of breaking that trust.
We're here to help support. That can give patients kind of a sense of security and approval that it's okay, we know that you might be feeling these things, and we want to be here to support you. The patient is the experts of their situations, leaving that door open to give help and resources for families in the process of also humanizing and holding them accountable, I think is an important part of ways that we can prevent intimate partner violence.
Trauma-informed care, our main goal is to not re-traumatize the patient, turning this perspective. What happened to you is not nearly as important as what it means to you. Understand reporting requirements. 0 to 17 years, all adult citizens are mandated reporters. Vulnerable adults are the next, those people who really rely on someone else, an immediate law enforcement or adult protective services reporting. Non-vulnerable adults, 18 plus, independent, they don't rely on anyone for any. Healthcare providers are mandated to report in Utah when we are treating an assaultive injury or if we know children are exposed to violence.
What do we do and how can we fix this is typically the question that I get regardless of who I'm presenting in front of. The very first thing that I will say to people, much the same as what we are doing today, is simply talk about it. Present about it, learn about it, talk to your colleagues, your friends, your family, your children about what does healthy relationships look like, what does interpersonal violence look like. Because historically, especially in Utah, we assume that this is part of the reason that we have such a huge statistic that overshadows the national average is in Utah, we have historically not talked about it. We have a culture that really is very much about dealing with family stuff at home and not talking about it or making any part of that public. And I understand the need to want to deal with stuff at home, but what's happened is because no one else is talking about it, victims think they're the only victim in the neighborhood, so to speak, and it would be embarrassing for them to bring it up or to reach out for help if they think that maybe it really isn't happening or it's not significant enough or no one would believe them or there wouldn't be help for them. And so they just aren't bringing it up, aren't having conversations. But if we can somewhat normalize the conversation about why we want to talk about it and why it's important and where there's help, more victims can actually connect to resources than are able to right now. And then secondarily, knowing about where the services are for help, knowing about Safe Harbor or other organizations similar to Safe Harbor is going to be critical, because you never know when someone's going to approach you with even a small situation or what seems like a small situation. There might be a large situation happening underneath that, but if anybody were to approach you, it's going to be vital that you know where the services are and what those services kind of look and feel like, so you can help walk them through how to connect to those services. Safe Harbor, we have 24/7 services, and what that looks like is we have a hotline that is answered by staff members. We have an emergency shelter that we can bring individuals into. We have the sexual assault nurse examiner services that I mentioned earlier, as well as the advocacy services. And right now, because of COVID, we are having to kind of be creative and put so many people in our shelter and so many people in hotels to try and keep them safe, both physically safe from their perpetrators, but also healthy from the pandemic. And so we're trying to be still creative with that. We have 3 facilities. We have our emergency crisis shelter that I mentioned. We have what's called our transitional housing apartment complex, where people can stay up to 24 months in an apartment environment. And then we have our Lifeline and Prevention Center, which is, for lack of a better way to describe it, our outpatient services. 80% of our clients utilize outpatient services, and we want that because when they come into shelter, we are immediately initiating homelessness. And so it's better if we can find a way to keep the client safe in their community so that they're not automatically homeless. If you can imagine, when they come into it, they're not able to bring any of their personal items, they're not able to really bring creature comforts with them, and then they typically lose their housing while they're in shelter trying to get reestablished and create that safe place for them. And as many of you know, there's not a lot of affordable housing that then we can rehouse them in once they come into shelter, and we're trying to then find some different options for them. So we really strive to stay in their home, stay in the community, and stay safe in those environments instead of having to come into an emergency shelter. In all of our facilities, however, we provide all of the services you see here under client services. So free therapy, children's services for the kids that are affected by interpersonal violence in their home, housing services, economic empowerment to try and help them get financially stable. We have psychoeducational groups. We provide a diversity support advocate for those individuals that may not speak English as their first language or may not be documented. We don't care if someone's documented or not. We provide the same services for them regardless. And then we have the lethality assessment protocol, which is an assessment that is done either by ourselves or law enforcement or both, which is an 11 questionnaire that talks about if somebody answers that the first 3 questions yes, or a majority of the total 11 questions yes, they're identified as a high risk for homicide. And at that point, we want to make sure that we are connecting them to safe options as quickly as possible. Now, just because they answer yes to these questions and we've identified them as a high risk for homicide does not necessarily mean they will leave their situation. And so what it does is helps us connect to them faster and make it more urgent to get them they need, but it doesn't mandate that they leave, and many times they choose not to leave. And so just kind of letting everybody kind of understand that as we go through this. So recognizing signs of trauma, there's all sorts of different aspects of trauma, and this is, I think, where the practitioners come in so critically, is being able to identify these areas. Just to touch on a few of them, cognitive trauma can look in many ways, but just listed a few of them here. So, someone's coming in with nightmares, loss of memory, they seem disoriented or confused or having severe mood swings, that can be related to the trauma. There may be many other medical reasons, obviously, as well, but that could just be the trauma that they're experiencing at home. We also look at behavioral signs of trauma, so avoiding activities or places that might trigger them. So if all of a sudden now they don't feel like that they can go to a family member's home, or coming to work trigger for them, it may be that when they go to work, they get punished when they come home, and so going to work, they know then is going to trigger some type of trauma when they return. And so finding that they are experiencing a lot of anxiety, maybe they're experiencing a sexual trauma at work, so you could see some of those triggering things. Lack of interest in previously enjoyable activities, so if they used to play pickleball all the time and now all of a sudden they don't want to have anything to do with any activities, that can be related to some of the trauma that they are experiencing. Some physical signs of trauma that we've seen in different victims. So insomnia, sexual dysfunction, change in their sleep patterns, complaints of body aches, or things that just can't be explained otherwise, could be connected to their traumas as well. Psychological signs of trauma, these we see a lot in victims. So overwhelming fear, the detachment from emotions. So you're expecting that maybe they would respond a certain way to maybe a death or a crisis, and maybe they're presenting themselves very numb and unaffected, or no action that can have some connections to that trauma. A lot of shame and guilt, you'll see that quite frequently. Irritability, anger, we see a lot of anger and anxieties coming out of individuals. And one of the things that we really focus on is being trauma informed and understanding all these different signs of the trauma, so that we can really meet people where they're at in their trauma, and that some of their behaviors and things that they're experiencing truly are related to those traumas, and not be dismissive of those things just because they don't make sense to us, or we wouldn't have responded in the way perhaps they're responding. So some additional tools for responding to disclosures. If somebody was to come into your office and disclose, just what do you say to a victim? How do you handle that when they come in and they disclose? And I know Micah, went through the different protocols on how do you connect them and getting them those resources, which I think that algorithm is a great tool for all of you. So, just listening, number one, without any judgment, because a lot of times our very first response is, I'm sorry that you're going through that. How can I help you get out, right? But many times when a victim does start talking about it, they're not in a space yet to be able to leave safely. And they may never get to a place where they can leave safely. The most critical time for safety is when they're trying to leave. And we know that, and we have to be really careful. A victim knows the very best when it's going to be safest for them to leave. Even if they're in the beginning stages of realizing that they're being a victim of interpersonal violence, they know when it's going to be the safest to leave. So there are some things that I think that you all can be doing, and I'll go into that in just a minute. But being able, one, to talk to them about the power will and the equality will, and telling them, talking to them about, what does it mean to be a victim, and that you're glad that they're comfortable in telling you, and letting them know that it's not their fault. Allowing them just the space just to talk about what's happening for them at home is really what they need first and foremost, not for someone to tell them to leave, because that's many times just not too much on their plate for what they're dealing with. Some additional things, the why. It's like, why are you staying with them, or what are you doing? We want to be really careful not to ask the why questions. We want to make sure that we're being supportive and that we're providing resources. Here's a resource of Safe Harbor, or here's some information about interpersonal violence, or here's some information about healthy relationships, but not asking the why are you still there. Many times they are really very embarrassed, and for them to even bring it up at all and be able to talk about it is a huge step for a victim, because there's a lot of shame and guilt in staying in that situation for them, and knowing that they're staying in that situation, especially if they have children that are being so asking them why just enhances their guilt and their shame in staying. And their recovery is going to be different. So just being very patient with that. They may come into you once a month for a doctor's appointment and use that as their way out, and a way to just be able to communicate where they're at now in their process. And so just being patient with what the process is. Don't take control of it. I've seen people in situations where, you know, they want the person to leave so badly, and they're in a position of authority, whether they're a physician or they're a nurse or they're a therapist or what have you. And so they pick up the phone immediately while the person's in their office and start making phone calls to crisis centers to get them out. And the victim typically feels pressured to participate in that, because we're in a position of authority in their minds, and so they're participating. But when they leave that office, then they don't tend to return, and they don't tend to come to us either. And so it's really turning that power over to them, really empowering the victim and letting them know where they can get the help and how to get the help, but letting them kind of do that in their own time, in their own way. Not that you can't say, if they say, can I use your phone here? I want to make this phone call. Most definitely that's a good support for them. But picking up the phone and saying, I'm going to call a crisis center right now. We're going to get you a bed. We're going to get you out of this house right this very second, is not typically the best way to handle a victim situation. Give them the information, help them, but don't take control of getting them out. Patient safety plan. And what does safety plan look like? Just being able to tell people, like, a safety plan isn't typically enough. And so sometimes, many times, a victim doesn't even know what a safety plan would look like. And so once again, we pre-printed these cards out to be able to give to different victims, to be able to say, you know, pack an emergency bag, give it to somebody else, or store it in a safe place so that when you're ready to leave, you have critical things that you can take with you. Make sure your documents are in order. Do you have birth certificates and social security cards or bank statements that you might need later on? Do you have copies of those things? Are you recording the abuse? And they may lean on you a little bit to record some of that abuse. And I got on the very tail end of Micah's presentation around the Cures Act, so I'm not super excited about that for victims, because they a lot of times have leaned on healthcare providers and therapists to be able to help record this information. And if their perpetrator can get medical records, which most of the time it's sitting, the perpetrator sitting the victim down and saying, get on, I want to look at it. Now, if they see that documentation, that's going to put them in some danger there. So being careful how you help record that. But if they come in, say to Safe Harbor, because we are covered under something different than HIPAA, we're covered under VAWA, we're able to take documents for them and make copies and take photographs of injuries or those type of things that nobody is able to then access later on. And so we're covered a little bit differently than that. Making sure that they're safe online or with their phones. Many perpetrators add tracking devices to the phones, and so they're being able to track where they're at, they're able to track who they're calling, what apps they're using, what websites they're getting on. And so being really cognizant and aware of those type of things. And then of course, just their safety escape plans in general.
Power dynamics and oppression and racism, and whose stories we hear about and whose stories we don't. I think that this is something that I've been thinking about a lot, especially over the last week with the shootings in Atlanta. Just to be very frank, the way that conversation has been framed about those women of Asian descent who lost their lives has been maddening. And an Asian background, and I can't help but feel so enraged just about how some of that has been discussed. And so I want to make sure that we name that and acknowledge that we, in order for us to fully embrace what we need to do as community members to address this issue from a primary prevention place, like we cannot tease out racism and oppression and power. It is very intimately involved with all of these topics. This is just some data from our University of Utah campus climate survey. So this is specific for students, which is the population that I work with. We launch a campus climate survey every 2 years. Last year, the 2020 iteration concluded right before the pandemic hit and forced the entire university to close. So the data that we have is from the responses from February last year. What I will say, generally speaking from this report, and you can find the full report online if you just search for Campus Climate Survey, University of Utah 2020, you can find it pretty easily, it's public. But what we do know is that most people do not report their experiences of IPV, which I do not think is a surprise to us. We know that it is a very underreported experience. When we asked our students, though, why they didn't report their experience of violence, the top 2 reasons were that they didn't think it was a big deal, or that they believed that nothing would be done. I think that is something that we very much need to pay attention to, that we have a number of individuals, not just students, but people throughout our communities who experience violence. And I know in the state of Utah, we're all very aware that this is an issue that impacts us at higher rates than other states. But most people don't share what happened to them because they don't think anyone's going to believe them, or that it's not going to be considered a big deal, or that there's this kind of this self-stigma of, it wasn't a big deal. People experience worse things. I shouldn't bring it up. And so I think that's important for us to this conversation, that we have to figure out how do we talk about this, because harm is harm. And we'll talk about this spectrum as well. The other piece is that most experiences of IPV are also not this stranger danger element. Most harm is perpetrated by people who are known to our victims and our survivors. It's usually by a former partner or a current partner, pardon my typo, or an acquaintance. So it's someone that they know. It is very rarely someone that they do not know. But yet I think when we think about this idea of IPV, it's usually, and I know that there was a campus alert that went out not too long ago about someone coming out from behind a dumpster. And so those are kind of the images that feel very scary to us. And I think that in order for us to have a very important conversation about IPV, we have to understand that most harm is perpetrated by individuals that we know. And then lastly, is this piece, though, that most people try to intervene when they see something that feels problematic. But what we also know is that the more concerning the situation is, the less likely someone is to intervene. And whether that's, lack of skill or a lack of confidence, we'll talk about that. Or if it's after an incident has occurred, so someone shares with an individual after the fact that they were assaulted, that they were raped, there is just this gray area of well, I don't know what to do, or it's already happened. And so we don't think of that as intervention. And so I'm going to kind of talk about all of this in terms of, how do we broaden our spectrum of understanding, and how do we really practice those skills of just checking in with the people in our community. A couple terms just to very briefly bring up, because when we think about also what it means to be a good community member, there are some elements that they really much change how we view what a community means to us. And so we have to acknowledge that we all have bias, and that bias can play a role in what it means to be a part of a community. I think this is something that we talk about a lot, especially over this last year, about, more and more of our people that are in our actual community coming out and being well, I don't feel like I belong here, And so when we talk about this idea of bias, I want you to think about, what it is that comes to your mind when you think about your community, because that's kind of the first step of raising our level of awareness of what it is that we actually think of, and who is missing from our community when we're thinking about that. And then also this piece of social norms. So when we're talking about social norms, it's a really important piece to bystander intervention, because what has become normal in our country, there's a lot of work that we have to do to make that not normal anymore. Because if it's, when we think about kind of the scripts that we adhere to, if it falls in line with what we are thinking is socially acceptable, we are less likely to intervene in something that's problematic. even when we know it is, but if it kind of falls in line with what we know to be a social norm, we are less likely to intervene. Briefly introduce what we use in our office, just because it helps to give some pretty clear steps about what we're talking about with this idea of bystander intervention. We use what we call the step-up model. And so just to very quickly go through it, the way that we talk about how we intervene in situations that feel problematic, the first step is that we actually have to notice. We have to notice what the problem is. Step 2 is that we have to interpret it as a problem. So we might notice something, but if we don't interpret it as something problematic, the rest of this is kind of pointless, because if we're not identifying something as a problematic situation, we probably are not going to intervene. From that point, once we interpret something as a problem, getting to that place where we assume responsibility. And then step 4 is evaluating what your role is. So what can you do? What should you do? What's safe? What's unsafe? We'll talk about some of those pieces as well. And then lastly is actually intervening. And I know that feels like a really lengthy process. I will say that steps 1 through 4, the more that we practice kind of noticing, interpreting, assuming responsibility, and evaluating what your role is, the quicker you are to be able to actually step up and intervene. But steps 1 through 4 are critical to this idea of bystander intervention. So we're going to do a little bit of a deeper dive, shifting and reframing, kind of like broadening this idea of what we're talking about with bystander intervention. And I like the idea of just talking about normalizing regular check-ins. So I encourage you to think about the people in your life, especially right now. The world is feeling really funky right now. And I know that we're kind of, there's some light at the end of the tunnel with this pandemic, and there's also a lot of pain and healing that needs to occur, or a lot of healing that needs to occur, and a lot of pain that people are feeling right now for a lot of different reasons. And so I just encourage you to think about the people in your life and think about how could you maybe practice some of these skills to just check in with those in your life. Looking at harm also as a spectrum, and kind of thinking about the things that we know absolutely are problematic. Yes, we need to practice continually to intervene in those moments, but how do we kind of broaden this idea of harm and practice intervening at much earlier time points? It's a challenge and it takes practice. And then again, this idea of calling in versus calling out. And then really at the root of all of this, like when we're talking especially about IPV, there is a lot of power and oppression dynamics there that we have to figure out how do we dismantle these systems that are bigger than each of us on our own. We have to figure out how do we come together to really just dismantle that and rebuild something that's better. And so I just encourage you all to practice, reflect,